Hello, it's Andrew Barron again. We're going to talk today about hip arthritis. This is one of the most common things in orthopedics that we take care of, and something that I do a lot of, and truly one of the most get back to activity surgeries that we perform, turning someone who's struggling with hip pain to being more active, hiking and everything. So it's a pretty exciting surgery, and I do love talking about it. So we're going to talk about hip arthritis. So hip arthritis is when the joint of your hip starts to wear out. The cartilage wears away. Generally, you start feeling pain, discomfort, pain with activity, even up to sleeping at nighttime and everything. And this is one of the most common surgeries done in the United States. Over 500,000 are done per year. So let's jump right in and talk about it. So hip arthritis, first we need to get a sense of the anatomy normally in the hip. So what I have here is a normal hip, and the hip is the connection from the spine down to your leg. So when we look at a normal hip, we're always looking at a little bit of the spine because we want to see, is this their problem? Does this add to it? It changes a little bit with what we do with the surgery. We then have the pelvis, and then ultimately the hip joints. So the hip joints are where the femur, which is the big strong thigh bone, meets into the pelvis, and it's essentially a ball and socket joint. And what we can see when we're looking at a normal hip here is the space. This space here that I'm drawing on this person's left hip is the cartilage. The reason it looks like, if we look back over here, the bones are separated from each other, it's because there's cartilage in there, and cartilage does not show up on the X-ray here, so we see the bones floating away from each other. That is the cartilage. This is what we want to see in a normal hip. If we zoom in a little closer, we get a sense of that cartilage there. We're looking both at the top as well as the inner side cartilage. We want to see how there's this space all the way around. We also look at the side view because that tells us some additional information. But still, when we're looking at arthritis, what we're seeing is this cartilage space around the hip joint. So these are two good hips. If this person's having pain, it's something else. It's not their hip arthritis. But then we can start to see what the comparison looks like when someone does have hip arthritis. So similar view, a little more zoomed in, we see less of the spine, but we're going to start talking about the left hip. All my examples here are on the left, so there's some continuity there. What we start to see is that space is gone, especially towards this inner side. There's even a big cyst that's formed on the top here. That cyst can be from irritation because the bones are touching each other now, so the cartilage is wearing off and starting to irritate the bone. That's when this starts to get really symptomatic. When the cartilage goes away and then the bone starts getting irritated, this is when we're starting to have increased discomfort and pain. So here what we see is narrow space, a little bit narrow space to the top, and then even some bone changes like that cyst there. Of course, arthritis can get worse. What we start to see eventually is now we're collapsing the head. It's not even spherical anymore on the side. It's completely bone on bone up here. And you can see on their other hips, still got some space there, but here completely gone. And actually it's taking the spherical ball of the femur and starting to kind of compress that down, erode away the bone. This person's now getting really symptomatic. Rarely do we see eventually get to something like this, where the head completely erodes. That could be from a fracture or a trauma. It can be from a thing we call avascular necrosis, where we actually lose blood supply to the femoral head and it starts to just die and disintegrate. This is now almost unusable. Now what is happening is actually starting to erode. This is getting to be a harder and harder problem. Here's what we call the acetabulum, or the socket side of the ball and socket joint, and we can actually see how this is starting to get eroded away. This is now getting progressively more challenging, obviously very symptomatic. So those are sort of the general stages of arthritis, from normal to about as bad as we see. Now, not all arthritis, in fact, a lot of people have variations of arthritis that aren't having surgical treatment. First of all, our goal is always to keep you active. Whatever choice we make together, we are trying to make you more active and do more of the things that you want to do in life. So at first, keep active. We want you keeping on moving. We want you to work on strength and flexibility, work on your body weight if you can. I know it often it gets harder and harder to walk, but finding things that keep you still active. That's what keeps the core, the muscle engaged. All of that protects your back. It keeps obviously your heart and lungs working well. These are all things that we want. People often take anti-inflammatories. Of course, we can just buy these over the counter, Aleve, Advil, things like that. There's other supplements like turmeric, fish oil that can work as a mild anti-inflammatory, but not have some of the side effects of the stronger medications. And people do take supplements. The data is mixed on supplements for arthritis, but they can often give some relief, and people do enjoy taking those because they get some relief in their hip. Eventually, injections, cortisone a little bit being the mainstay. Once we get bad arthritis, it's the one that tends to work the best. People are often worried about the downsides of cortisone. Really, once you have really bad arthritis, the downsides are pretty negligible, because ultimately, if we do a hip replacement, it doesn't matter if someone's had 1 injection or 20 injections. There are PRP and stem cell injections that people talk about. PRP is using your own blood. Stem cell, a little more controversial, more expensive, not really shown to provide the benefit of the for what the cost is, but there are some doctors out there that will tell you about stem cells. PRP, using your own blood to sort of control that inflammatory biology of your hip. When we get to doing surgery, a total hip replacement is what it is called. Total in that situation just means we're replacing both the ball and the socket side. Okay, that's what total means, both sides of the hip joint. And even then, when we're doing a total hip replacement, the majority of what makes up what we think of as our hip stays in place, including the hip capsule that contains the hip, all the musculature around it, including the abductors, the flexors, the glute musculature, and the majority even of the ball and socket. You'll see on my example here what is removed and what goes stays behind, because we need all of that support structure to make the hip work right. Really, all that we remove are the femoral head, the torn and degenerative cartilage, and the labrum, which by this point is always torn in the hip. So if you've been told you have a labral tear, but you have bad arthritis, well, those are just part and parcel. Those are two of the same thing, and we do remove the labrum when we do the hip replacement. There can be other sources of pain around the hip. So if we get, again, this hip x-ray and they're having a lot of pain, we're looking for something else. Oftentimes from the lumbar spine, pinched nerve causing pain down by the hip. If the pain is in the back of the hip or the butt, we're not thinking hip as much as in the groin. That's where classic hip arthritis hurts. You could have a muscle injury. This can be painful around the hip from a hernia, from nerve injury, from pelvic pain. There's lots of other sources, hip arthritis being one of them. So our first goal, and sometimes we use an injection to help us figure this out, our first goal is to figure out, is this hip arthritis causing the problems? Once we've determined that, we start to plan a hip replacement, okay? So we're gonna use this patient as an example that we looked at before, the one that has the cyst, the narrowing of the space, the bone spurs that you can see around the hip here. So this all starts way before we're in the operating room. We are planning this surgery well ahead of time, because you'll see we use fluoroscopy, which is live x-ray during the surgery, to plan this all out. But it starts with what we call templating. So we use a computer program to plan out. First, we calibrate your x-ray so that we get the correct sizes, and then we'll actually go and put in the cup and the stem and the size of the ball and everything to make sure we're always dialing in the leg length, what we call the offset, the side-to-side width of the hip, because everyone's built a little bit differently. Oftentimes, if the hip's really bad, like some of those examples, we'll template the other side. We'll actually template over on the other side, because that's the normal. That's the good side. Let's make it match the good side, because we don't have enough information, because it's been destroyed on the bad side, that we'll go and template this. But this will give us exactly the angles that we want, the size that we want, and of the cup, as well as the size of the stem. So we know going into surgery what to expect. Then when we get to surgery, this is some snapshots of live x-ray. So starting in the middle here, What we want to see is we want to line up the pelvis, okay? So we want to find, just like doing construction or cabinetry, we need to find level, okay? So once we find level, which is the pelvis, then we can go to the good side, over to the left here where we're not doing the hip replacement. And what we start to do is line up where we're at with the hip relative to the pelvis. So we can start to see these landmarks of where they line up. And using the computer and our templating, we can identify where all of these cuts need to be made, okay? And so here's on the right side of the screen is after the replacement, okay? So we've made the cut. These are actually the trials, what we call the broaches, so we can still adjust the size and location. What we're looking for is the offset of this, as well as the length. And remember, we looked over on this other side, the top of what we call the lesser trochanter lines up with the pelvis here. Same thing over here. So we like our length. Our offset is how far apart this is. This is our offset here. That's all looking really good. We like these implants. We can dial in the size of the cup, the size of the stem, the offset of the stem or that neck angle, as well as the distance for the ball portion. And so this is what a hip replacement looks like. These are the components of a hip replacement, okay? So there's four. There's the cup, there's the liner that goes inside the cup, there's the ball, and then there's the stem. So the parts that grow into the bone are the stem that's into the femur, the acetabular cup that's into the acetabulum. So if you were to look into a hip replacement after we're done, you would really just see this portion. This portion is the part that actually articulates. And what we use is special polyethylene plastic, and this is a ceramic ball, and this is adjustable, this length, this angle of the neck is adjustable. And then obviously the sizes of the components, because we take care of everyone from, 5 foot nothing to 6'6", and they all need to fit. So there's lots of sizes of all of these. Once we're done with the surgery, this is what it looks like, and you can get a sense that this component is what we put in there. What we have is the cup, the ball. What you can't see is the liner because the plastic doesn't show up on the x-ray. The neck, which we've chosen this angle as well as length, and then the stem. The stem and the cup will grow into the bone. When we have big cysts, we'll also fill them with bone graft, take it from some of the bone that we take out and pack that so that it heals up, but you'll still see it on the x-ray like you see right here. So this is what a hip replacement looks like. We've controlled the offset, we've controlled the length, and this is all done using live fluoroscopy and the computer templating. So the way that I do this surgery is from the anterior approach. I encourage you to look and read. There's some other ways to get into the hip joint. This is really becoming the way to do it. We don't cut any muscles. We go around them. We have to make a skin incision. We push the muscles away, but don't cut any of them. Everything is repaired on the way out. All of the layers, the capsule, what we call the tensor fascia lata, and then the skin. It's a little bit more challenging, or at least historically, and requires special equipment. We have a table that's just for this. It's 100,000 plus just for the table that you're on during the surgery, as well as special equipment during the surgery. So it's a little bit of an upfront for us, but way better for the patient. Surgery time is about 40 to 60 minutes, generally a spinal anesthetic. We do put local injections at the time of surgery. Most people are pretty comfortable after this operation. It's an outpatient surgery. You go home the same day, you come in, you get surgery, you work with physical therapy in our facility and get up and walk around and even do stairs, and then get home. And the recovery is done at home. The general time frame, about, it's a little bit variable for everybody, but about a week of really just kind of chilling out, ice, rest, walking with a walker. By 2 weeks, a lot of people have transitioned off the walker onto a cane. Kind of depends on your baseline conditioning. People that are really strong, people that are fit going into it, obviously a little bit quicker. The only restriction you used to hear of people, you can't sit straight up for months and months and months. You can't sit on the toilet. You can't do things like that. That's all the old way, the posterior approach. So the opposite way that we do that, where there's a risk of dislocation because they do cut through the muscle. There's a very low risk of dislocation with the anterior approach that we do because we don't cut any of the muscles. The only thing that we say is to not hyperextend or do back bends for the first 6 weeks. That's really it, sitting fine. 6 weeks, essentially, we have no restrictions. Most people at that point are returning to work. Definitely you're, in the gym, going on walks, being active. 3 months, full activities, golf, hiking, skiing, things like that. People do continue to heal for a full year afterwards. Obviously, this means you're not down the whole time, but you continue to get stronger and feel better with this hip for a full year after the operation. So that is hip replacement. It's one of the best surgeries we do. It's one of the best return to the quality of life from before surgery to after surgery. And I hope this video helped you understand what we're looking at and maybe inform you on what goes on if you're facing a hip replacement. As always, please give us a call or contact me, see us in clinic, and we can see how we can help you get through this. Thanks a lot for watching.